My name is Dr. Peter Ingham, and I am a practicing GP. I practice in Sutton Coldfield, and I've been working there for almost 30 years now. But I'm also clinical chair of the Birmingham and Solihull CCG. The CCG is the organisation that is responsible for ensuring that healthcare services are provided for its population. And in our case, that population are the residents of Solihull and Birmingham. We were formed on the 1st of April 2018, and this therefore is our first AGM, and we have recently published our annual reports and accounts. I would like to introduce you to our panel, who are not sitting at the front here, but I will introduce you to Paul Jennings, our Chief Executive, Phil Johns, our Deputy Chief Executive, and then moving down to Karen Helliwell, who's the Director of Integration, Paul Sheriff, who's our Director of Organisational Development and Partnerships, and finally Richard Mendelson, who's sitting at the front, who is our Chief Medical Officer. The format for this afternoon, I will take you through some introductory slides, just speaking for around 10 minutes. Then I'll hand over to Paul Jennings, who will then be followed by by Phil Johns, who will talk about our financial position. So as we look back at our first year as an organisation and the successful merger of 3 clinical commission groups, that's to say Birmingham Cross City, Birmingham South Central and Solihull CCGs, to form a single CCG, the largest single CCG in the country, I have to say that I am both delighted and truly proud of the significant progress that we've made to date. But what does that merger give us? Well, it gives us the benefit of having a single leadership team and a single commissioning voice, which I believe has added greater clarity and stability to the wider health system. That voice has enabled us to work much more closely across health and social care, and that has led us to become a much stronger partner within the Sustainability and Transformation Partnership. Now, the SDP, or that partnership, brings together our 2 councils, our trust hospitals, primary care, community care and mental health, all to work together to try and integrate health and social care. And I'm pleased to announce that our Chief Executive, Paul Jennings, has been elected system leader of our STP. So we've come a long way in our first 12 months. We're on a journey towards becoming a more strategic commissioner. And that means tackling local health challenges with our partner organisations. That means working more closely with the council, for instance, or our trust hospitals, or the community trust. It means ensuring that patients can access joined-up care right across Birmingham and Solihull. And we must do this while we focus on what really matters to you as patients. In healthcare jargon, we talk about reducing health inequalities and improving health outcomes. But what does that really mean? Well, it means that no matter where you live in Birmingham and Solihull, no matter what background you come from, you should receive the best healthcare and have the best opportunity to live a healthier life. And we have to do all of that, deliver all of that within the finances that we've been given. And we can only do that by making the best possible use of the public money at our disposal. We've been working over the last 12 months with general practice very closely. Firstly, we've been working with our GPs to improve patient care. So we've been working from the grassroots up with doctors and practices to deliver a consistent service right across Birmingham and Solihull. So that means that practices will deliver the same services and work to the same operating standards right across Birmingham and Solihull. And we call this our universal patient offer. In practical terms, that means that if you now go to your practice and you require or need an ECG or lung function tests, those can be delivered in-house in the practice rather than you needing to go to the hospital. And again, I'm delighted to say that 100% of our practices have signed up to the Universal Patient Offer, and that offer is out and live, and patients are accessing it right now. The second thing we've been doing is working with our GPs to improve the availability of appointments. And now 1.3 million patients can access evening appointments and weekend appointments. Our 168 practices have worked together to create local hubs where they can deliver these extra appointments. And I'm delighted that 100% of our practices have signed up to offer this. We've also been working with our GPs to look at different ways that patients can access their practices. So many of you will have smartphones. You'll probably already be doing online banking or online shopping. But here, you can undertake healthcare and you can access your practice by using our own BSOL app. The BSOL app will allow you to make appointments or even undertake a video consultation with your own GP on your phone. And we're going to be rolling that software out, that app, over the next 2 to 3 months. So general practice, however, is under pressure. You probably will have read that there's a national shortage of GPs. And certainly, I believe it is quite a tough time for primary care. Certainly, it's a tougher time than I can remember. But in my visits around the practices and the localities within our CCG, I've been so impressed by the quality of primary care that is out there. And I think that we have an amazingly strong primary care offering across our CCG. But we need to help sustain that. We need to ensure that we work to retain the GPs that we have already working here, and also attract other GPs to work alongside us. So we have 5 schemes which I'm just going to run through that try to support primary care. The first scheme is the GP Retention Connect scheme. So this is a scheme whereby GPs can undertake projects. They're allowed protected time away from the coalface to undertake projects which will improve patient care or improve the processes within their practice. This has been a very popular scheme and has been fully subscribed throughout. Our second scheme is the First 5 Network scheme, which looks to support GPs in their first 5 years of general practice. It's a shocking statistic, but over 40% of GPs will leave general practice within that first 5-year period. So we've put forward a mentorship scheme, and we have 2 young, proactive GPs who are working with that group to help and assist them through that critical phase. GP mentors. We've also been looking at working with GPs at the other end of the age scale, so those GPs that have huge experience and been working in general practice for a long period of time. And we're asking those GPs to mentor practices and work with them and share their knowledge and their experience. We have the GP Peer Support Team. This is a unique service for our CCG. It's something of which we are very proud, and I see Aftab and Ravi in the audience. The team comprises managerial support and senior clinicians who will work individually with practices to support the practices to take back their concerns, to share best practice, or to work with the practice ahead of their care quality commission inspections. In fact, we have mock inspections that are undertaken, and this has been so popular as a scheme that we're now extending the offering and including practice managers and practice nurses within the team. And finally, we have International GP Recruitment Scheme, and we have been out to recruit GPs from across Europe, and we have several GPs who are now embedded within practices and working within practices across Birmingham and Solihull. So looking towards the future, All of this good work must continue as we look forward into 2020. And in 2020, one of the biggest contract changes for general practice for a decade is coming into being. And this is going to attempt to relieve the pressures and the stresses upon general practice. And we as a CCG will be looking to deliver the outcomes planned within the long-term plan. And one of those elements is the creation of primary care networks. So primary care networks are a big feature of the long-term plan. These are about delivering services in your community and integrating those services. GP practices are coming together to work to look after patients of a population size of 30 to 50,000. And although general practice will be at the heart of these primary care networks, other services critically will wrap around those primary care networks so that district nurses, paramedics, pharmacists, social care prescribers, mental health workers will all become critical parts of the primary care network of the future. So as a patient, you should seek more personalised, coordinated and integrated care. And I'm also pleased to report that our 168 practices have now come together to form 33 PCNs across Birmingham and Solihull, and these have recently been authorised and approved. So, in closing, I would like to thank all of the practices, all of the CCG staff, all of our many partners across Birmingham and Solihull, and also the patients who've contributed and assisted us over the last 12 months. And I hope you'll join me in looking forward to a really exciting 2020. Thank you.
I'm going to find it, and a man in black will appear. It's in my magic. There we go, the act. It's not an act, it's all real. It's fantastic to see so many of you here this afternoon. It's brilliant to see you all. Thank you so much for coming. I want to just sort of capture the moment. So if you could all just simultaneously smile, I'll give you a wave. Thank you. I will tweet you later. Thank you. Fantastic. So I just want to talk about our priorities and a couple of other things this afternoon. I shan't keep you very long. These are the things that we are here to do as a clinical commissioning group, as the largest, as you heard from Peter, the largest clinical commissioning group in England. We are here to try to make these things happen for you. The key issue for us is clearly around health inequalities. As you look across Birmingham and as you look across Solihull, they are both areas that suffer from huge health inequalities. In fact, the health inequalities, the difference between those who enjoy the best and the worst health, is worse in Solihull than it is in Birmingham. An age differential in terms of lifespan of 11 years in Solihull from the best and longest lifespan. So real energy for us to go into the issues of tackling health inequalities. We need to work on creating this integrated system, and I'll talk about what that means in a little bit towards the end of my session. And along with all of this, we need to think about how we don't only concentrate on illness and disease, but how we concentrate also on health and well-being. How do we move up the river of health and see what's pushing people into the river of ill health? How do we stop that happening? How do we capture them before they fall in, rather than as a health service we're trying to whip them out and save them when things have gone wrong? So those are our three priorities as an organisation. We're proud of what we've done so far. We have made really significant progress in terms of working towards an integrated system, working with particularly our local government partners I'll talk about. We're making some progress with children's services, and you will all know, and it's, hands up from us, there have been some major issues around children's social care and health services in Birmingham. We've made great progress around diabetes, and as you've heard from Peter as well, the business of moving to a situation where all of our GPs are working to an equivalent plan, an equivalent offer across the whole of the patch has been a remarkable piece of progress. I've been an NHS Chief Executive now this is my 21st year. I obviously started the job as soon as I left school. This is actually the smallest NHS organisation that I've run in terms of number of people who work in it, because, as I'm sure most of you know, we don't actually directly deal with patients. Our job is around the planning of services, the commissioning of services, assessing of need, balancing the books, looking at the quality of services of those of our providers across the system and helping to maintain and improve where we can that quality. But I'd like to say a special thank you to our staff as part of this presentation. They've been through a pretty bumpy ride, moving through organisations for a while, through restructuring, through management of change, through a flood. We actually had a flood at headquarters. We had a plague of flies at our headquarters. Honestly, this is true, we did. So it's been a tough time for our staff. They've done well and they've worked well. And later on, earlier this evening, we're going to be having a long service award for 60 of them, celebrating collectively nearly 2,000 years of service to the NHS. And it's one of the things I think that I've always valued about being part of this public service, is that once people are in it, they appreciate the value of it, they join the mission, and they become part of it and stay with it, really very often for the whole of their life's careers. So it's been a fantastic piece of work they've done. So going forwards, what are we looking to do as an NHS? Well, first of all, we had published in January of this year the long-term plan. So a very lengthy and complex negotiation between the NHS, the leader of the NHS England, Simon Stevens, and the Treasury and departments of government. And we know how much money we're going to be getting for 5 years, which makes it an awful lot easier to do your planning if you're not planning from 12 months, at a time. So we understand what's coming, into our tills to spend. We do know that whatever comes into our tills to spend is generally more than a match by what's coming out in terms of rising costs. But at least we know where we're going. And the long-term plan has some really exciting things in it, particularly, actually, what was Peter's already mentioned, this business around primary care networks, a focus on trying to bring services together. And that's where the integration piece comes in, which is listed as the last of these boxes here. But the integration piece for us, we think, is really, really powerful. It happens in two ways. It happens through the clinical commissioning group working much more closely with local government, trying to jointly commission services. So instead of us over here deciding what we think we need for children and local government deciding over there what they think they need for children, we get together, we share the resource, we identify the resource, and we spend it together. And hopefully that way we create more efficiency, we have less friction between services, less opportunity for people to get lost in the gaps between them. And we also have an opportunity for integration at the local level. And I think this is a really exciting piece. So GPs have identified themselves into groups. Those groups are bounded by geography, not by just who your mates are. They're bounded by geography, so they've got a real opportunity to serve a local population. And we have an agreement with the providers, the large NHS organisations who provide services, that they will model their management arrangements around those groups as well. So we'll have community services, mental health services, adult social care services, local voluntary services, working within those populations, trying to make those changes happen, really making integration come together. And that will give us a greater opportunity to get closer to patients, to service users and to citizens. That will give us an opportunity to drive more efficiency and to change the way that we do things, to move to a system that's much more around what we call an asset-based approach. What can we collectively do together rather than what do we individually need. And that's a really, really powerful change in our system. It's something I really look forward to being part of. So those are our big ambitions, our big drives for next year. And I'm going to invite Phil up now to talk to us about balancing the books, which is something actually he's rather good at. Phil, over to you.
So good they've got somebody else to do it next year, but fine. As a CCG, we spend about £1.8 billion, broadly with 2% of the NHS in England. That is the money that our elected representatives see fit to pass through to the Department of Health, to NHS England, down to us as a CCG. Within that, about 10% goes out to spend on general practice. Roughly half is spent on the acute hospitals, QE, Heartlands, Good Hope, Solihull hospitals, around 200 million on both community services and mental health services. The hospitals that you all use, primary care that you all see, all comes out of that funding. This is a really constrained time for the NHS in terms of finances. Last year was probably as tight as I've known it, and many people say it's always the tightest year. When I talk about it, that's probably true as well. But in terms of growth, last year was the lowest we've had on the back of a number of years of low growth. Therefore, I think it's a considerable achievement the CCG, through the efforts of staff and wider partners, managed to balance its books to meet its financial targets as agreed with NHS England in 2018-19. We also received some additional funding for specific areas, largely around primary care, the areas that Pete talked about earlier, particularly the funding to start implementing the extended access appointments across all of our general practices. Additional money was also received, both for perinatal mental health, so mothers and babies can receive specialist services in the appropriate units and closer to where their births happen, and also for learning disability patients in terms of moving patients who for many years have often been held in out-of-areas facilities back into the city and more community-based facilities. 1.3 million also came in to support the Birmingham maternity programme, BUMP, and that work has continued to progress into this year. Once we met our financial targets, we actually had a deficit last year, £3.6 million. That is allowable in NHS England terms because in previous years we have underspent our allocation. We did that knowing that the financial regime was getting increasingly challenging over future years, and it was a way of smoothing out the challenge that we faced each year. We still have what's called a cumulative underspend as a CCG, so there's £34 million of surplus that we have to seek permission to be able to utilise on services for the general public over future years. We're taking a similar share of that, we think, into the next financial year, and we will be coming up with a case, we think, as part of the sustainability and transformation plan as to how we might access that additional money. So in any surpluses you've seen in future years, past years, built up across the 3 CCGs, is still available to us to spend, but it has to be done in a planned and considered way. So our allocation as at the end of the year, £1.8 billion. These are huge numbers. We have to almost sort of land on a postage stamp, really, because we've got to try and hit a balanced financial position on £1.8 billion. It is very challenging. It gets more challenging each year, but with the support of my colleagues, as Paul has said, now working more closely with partners and with local authority partners both in Birmingham and Solihull. We do have a plan coming into this year that we believe we'll be able to balance again. That's all I'm going to say. I believe we're now moving on to take any questions you may have. Thank you. I'll call the panel, is there?
Yes, it's panel time. I look better standing up, I think. So, moving amongst you are some of our colleagues with microphones. Yes, there's a gentleman here. If you'd like to, is the first one to raise his hand. Gemma's coming to you, but she can't run that quickly.
Graham Slater, Sutton Corporate Group Practice, CCG. I just wondered what were the 3 largest expenditures that you have at CCG? What are the top 3?
That's a Phil question.
That's presumably one for me. So actually, it's the 3 large acute hospitals in the sector. Half of our spend goes to those acute hospitals. They consume most of our spend, so the 3 biggest areas all go there. Within that, roughly a third of that spend is on urgent care, on A&E, people admitted as emergencies to hospital.
Thank you.
Okay. Next question. The gentleman here, Caroline, keep coming forward, this is on your right there.
Hi, Dr. Bangash. The inequality that was mentioned, to me, it still exists to a large extent. I think Paul Yanning knows. Right from the beginning, our efforts were to improve that. Various governments in tried, the one government not mentioning the name because of the parties, brought Professor Bessenquist to locate the most depressed area. And then there was some additional fund available to them. I wonder, we were talking about on a broad basis, which I'm glad to see some, but there isn't any statistic that those deprived areas have been provided doctor-wise, nurse-wise, health visitor-wise. They're still lacking, and those are the things that put the population differences to me, as far as I know. I would like the panel, what solution you have for that to remedy.
Thank you, Nawaz. This is one of our longest serving GPs who's worked in one of the toughest parts of Birmingham for many years. So thank you for all that you've done to address those issues. Dr. Bangash. Richard, do you want us to kick that off?
Yeah, I think the NHS plan is quite helpful because there's, I suppose there's a whole set of initiatives around inequalities. And as Paul said, you know, it is something that goes right to the heart of what we want to do. But they're persistent, aren't they? It's to do with something about social mobility and the way there's almost a structural problem within the different parts of the city, both Birmingham and Solihull. So wherever you look, some of the solutions have to be something about how we make services available in terms of access, and we're looking forward to working more closely. I think we've had a somewhat difficult time piecing back together the public health system, which we started to do in the last 12 to 18 months. Because I was part of a previous system where actually public health and an integrated approach into commissioning of public health was part and parcel of what the NHS did, and probably to a lesser extent at that time what the local authority did, and now it's moved over to the local authority. So we now have a joint group, a prevention group, where we work with our directors of public health, and that's new, that's only existed for about 4 or 5 months. We're looking forward to the plans that start to tackle inequalities. So whether you're talking about particular areas of disease, so diabetes, respiratory, etc., or some of the wider determinants of health and the policies that both Birmingham and Solihull start to look at. So if you're looking at, say, obesity, that's an important area, or say smoking cessation. So we're starting to look at tobacco control in the round, and there's quite a lot that I think you'll see happening over the next few years. And I would look out for some reports. So there's meant to be, I think it is slightly stuck at the moment, there's meant to be a green paper on prevention that's coming, and they promise this as part of the NHS long-term plan. And that will help to shape, I think, local policies. We've had the Marmot review. We've started to do a lot more around children. And one particularly exciting thing that we haven't had before, and I think it goes back to, was it Professor Bosanquet? Was that the... Well, I remember that report. And it was about the villages and the difference. So how do you recreate that but systematise it? So we're starting to do something called population health management, where we bring together all the data. So for the first time, we're having a conversation across the board, whether it's jobs, accommodation, schools, health, and the kind of social care that's provided, and bring all that data together, along with, we hope, things like police records, so you can look at communities in and around. And I think that could be quite powerful, because quite frankly, I agree with you. I don't. If you've lived here long enough, you don't. We haven't seen a lot of movement. I think there are kind of micro stories around the way primary care networks might begin to look at this on a population base, but I'm quite hopeful that we've got more tools in the toolbox now than we've had for a while. So in a sense, I agree with you, but I think I'm hopeful that given where we are, we'll be able to tackle it a bit more systematically.
Okay, thank you. Next question. The lady here.
As a member of a patient participation group, I think in terms of the budgets and the numbers you are working with, I can't get my head around that, but managing my own household budget, I think it's a time when money's tight. For me, the frustration is all the people who don't attend their appointments, who don't go to their hospital appointments. And I think there needs to be some education of us as patients as to what that actually costs and what that means in waste.
Karen?
Yeah, I think that's a really salient point, and I think there's a number of areas in which we can help both your groups at a GP level and the PPG groups to get that message through. What does it mean when a number of appointments that could have been used for urgent appointments are wasted? And I think there's also the use of new technology. I think that both Peter and Paul have mentioned about how that can actually help, both whether it's text messaging or the use of video, where you actually have better use of your appointments. So I think it's a really good point, and I think we'd welcome views from patients, both from hospitals and GPs, as to how best we can get those messages out there. So I would absolutely agree with you.
I think it's sometimes just knowing the cost.
We certainly, I'm sure, would be able to do that. Absolutely.
Yeah. Anyone else like to ask a question? Yes, the gentleman here at the front. Over here, Caroline or Gemma. As far, actually physically as far away as you could possibly be from where the microphones currently are.
Barry Austin. I'm a patient and also chair of the book practice for the PPG. The lady's question is very valid, and in fact it was discussed in our last meeting, so that we're going to look very deeply into it. I'd welcome the help in respect to this. I want it in the surgery waiting room with the figures up there, and I think if hospitals... Sorry.
Animated, yeah. Has to stay there.
I'm going to have it in the waiting room, the figures. I want to see it up there, so every patient can see how much it is really costing us. And I'd like to see the Queen Elizabeth Hospital, because I know their figures are really through the roof. They advertise it, but how much is it really costing our hospital?
Yeah.
I've got one other question I want to raise, which is concerning A&E regarding when they bring the patients into A&E, that the paramedics have to wait a long time, and I've said for a long time that this needs to be looked at as a study, because it's costing the NHS thousands of pounds. It really is. They are skilled people. They need to be out there doing the job.
I'll let Karen pick that up. That's something we've done a lot of work about, and although you hear a lot about it in the requests, that's something that is not a major issue for this city. But Karen, you want to pick that one up as well?
So your 2 points, certainly in terms of help around the wasted appointments and the costs, again, we'll certainly be able to help and pick that up. And there may be other PPG groups in that pilot as well. As far as A&E is concerned and the turnaround of those ambulances, you're absolutely right. And part of our work as a system partner, we can't do this alone. We work through a group called the A&E Delivery Board, which involves the major hospitals, the Ambulance Trust, ourselves, and the GPs. And that's the group that really looks at these particular areas. We look at the data, we look at the quality, we can't forget what that impact is for families and patients of waiting out in an ambulance. So, you know, it's absolutely looking at the round. And what are the initiatives that can help reduce those delays and handovers? And they range from everything from the efficiency of the department in the trust, what can they do, how can they use their staff better, to actually how the ambulances are deployed in the first place. You know, how do we make that more intelligent to avoid those blockages? So that group meets monthly, and I can assure you that those figures are reviewed, and areas that we can improve on that are monitored and initiatives monitored on a monthly basis.
Thank you. Lady here, right in front of you, Jim.
Just wanting to know, I'm sorry, my name's Gillian. What do you do for GPs as recognition? Because I've got one of the best GPs in England. And I just wanted to know, how do I feedback to let the whole world know, basically? And how do patients feedback?
Well, that's good to know.
That is good to know.
As a GP, positive feedback.
I think you can, I mean, there are some, you know, there's some online things, aren't there? There's patient feedback. But you know, it's really nice, as someone who, as a GP myself, who has to have an appraisal, it's really nice to get a letter from a patient to say thank you very much, because we have to collect all things like complaints, but there's also an ability to collect compliments. So it's really nice to get compliments. But I think it's probably something we should think about in terms of how we recognise some of the fantastic practice right across the board that we've got, and those are improving.
We have our awards tonight.
Yes, and we've started first year with our award, so we'll think about that. Thank you. But yes, a personal touch would be really nice.
Thank you.
It's good to know. Thank you.
I think it's a free service, that's why people are taking a wrong advantage. Those who don't, those who miss their appointment should be charged for, then they will learn to listen.
I've often heard that said. I have to say, it'll be over my dead body. The NHS is nearly 71 years old, and the essence of it is it's free at the point of use and need, and that is one of our national treasures, and I will fight to the last breath to defend it. But I understand where you're coming from, but not on my watch. Next question. Thank you. Have we got a question? Yes, Caroline's en route.
Thank you. It's just a detail in the account, sorry, not a very exciting question. It might be something that needs to come back at another time. There was an underspend on primary care other, about £7 million, 15% spent less than was intended on that particular area. I'm not sure what it's made up of. Just hoping it's not an intention to keep underspending on primary care. Really.
So we are tasked, I think you know, Pete, around spending our main primary care allocation. I believe I know what that is, because we inherited a number effectively of balances from predecessor CCGs, and that's just how it worked in the accounts. If I'm quite honest about it, it was released there, but it doesn't actually reflect against what we spent in primary care itself, so it's just where the accounts forms that we had to submit.
checking some instructions from my comms director. She writes everything I say, actually. She makes it all for me. Anyone else with a question? Yes?
Thank you. Just following on from the gentleman who talked about charging, I think what would be helpful is that I know there are systems on other avenues where if you're not able to make your appointment, at least how we can promote to encourage people to say, I'm sorry, I'm unable to, so you're freeing up that space to enable the doctor or the receptionist to be able to try and allocate that if needs be. My other question, Paul, is that there are people as well that rather than going immediately to make an appointment with the doctors, they actually then think, well, I could go to the pharmacy and ask information there, save clogging up. And also, I know we see, Paul, lots and lots of apps that are coming on where you can do a bit of diagnosis on that and get advice. So how are we promoting those, Paul?
So, in terms of the app, I'll let Karen pick that one up in a minute. Our app that we're building is, I think, mainly a transactional app at the moment. It doesn't do the advice piece. On the missed appointment things, I think I'd like to add, alongside of the monetary issues, it's the fact that somebody else couldn't have had that appointment. And to be honest, that kind of bothers me more than the wasted money, is that somebody else has had to wait longer or moved down a queue because somebody, for whatever reason, couldn't turn up. So I think the money element is important, but I think if you're trying to persuade people to think about why they should always attend or let people know they're not attending, it's about the missed opportunity for somebody else as well. Do you want to talk about apps, Karen? Karen and I are digitally babies, but you'll never go, aren't you?
I shall attempt ably to answer about apps, but I think you're absolutely right. The app that Peter talked about earlier, the BSOL app, it does have the ability to order repeat prescriptions. So again, if you're looking at the sort of opportunities and to try and encourage patients to use the app, there is some saving there. It is for booking appointments, and also it is a much easier way to access your records and any advice or information. I think the advantage going forward is that you may also be able to get your consultation online. So I think for quite a large amount of the population, not everybody, I accept that, because including myself in that, face-to-face or other ways are. But I think for a lot of the population, just checking your appointment, having a text, looking online is the way forward. So we are going to encourage that. You can't just produce an app. We need to encourage PPG groups and patients to get involved in that communication. I think in terms of community pharmacy and using them as a good information and support, guidance and a number of services, I think you're absolutely right. I think one of the partners that we talked about bringing into the SDP needs to be our community pharmacists, and I think we absolutely could utilise their services and advertise them as well.
Thank you. We've got time for one last quick, really easy question.
Easy, Dr. King.
Easy, Dr. King. Easy, Dr. King.
No, it will be. It's just picking up on the health inequalities question. Obviously, living in Birmingham, you just have to walk through the city centre to see the issues around homelessness. Yeah. It's great that you're working really closely with the local authority and looking much more at system planning. And I just wondered if there was any update on how we're going to approach homelessness in our city moving forwards.
Can you pick that one up, Paul? Because that sits with the localities group.
I was waiting for my turn. I was thinking as this was progressing, it would get more difficult, and I'd end up with a question that I couldn't answer. So I'm going to pretend I could have answered all the other questions, and this one I'll stumble over. But in summary, I think you're right, Barbara. To be honest, I think I was walking through Birmingham yesterday, and actually other parts of Solihull, certainly North Solihull, there are those issues are there for us all to see. This week, actually, there's a joint post going out across Birmingham in particular around looking at the leadership that's required to join up different parts of the health system with the local authority. So I haven't got the detail, which is my way of avoiding answering the question specifically, but I think there's a recognition we've perhaps all done things individually in silos, and actually the opportunity here has to be to how we join things up. So I think it's probably one to take away, and I think it's something that we'll be debating at our future governing bodies.
Carol,
Yeah, I think just to add to that, Barbara, I think there isn't just the pace. I mean, we have our own leadership in the CCG, both within mental health and through our partnership teams alongside primary care, and working with West Birmingham as well. And we've had a number of roundtable events to develop a strategy, both with the council as well. So that's going back to the Health and Wellbeing Board next time. So there will be a quite comprehensive action plan. Some of those actions have already happened, such as the review of health exchange at the Mental Health Trust. So that's improved primary care for owners. That's not to say there is not more work to be done, but a lot of it is around that coordination and the sort of next steps around the action plan. So I think please watch this space on that, but yes, I absolutely agree with you.
Yeah, so if I could just say it's the first formal population health management subject that's being done, because I think homelessness in its full definition includes, I think it's called precarious housing. So people who are just on the tip, and obviously I think there's a trajectory, so trying to understand when you bring together all the different kind of data that you've got from benefits, so that it's actually the first thing we're going to look at. So yeah, account for that product.
Thank you. Can I just, again, thank you all for coming this afternoon. It's been fantastic.